my name is Lanter, and today I will inform you about anorexia nervosa. So I'm sure that some people in this room know someone who is on a diet. However, what if you couldn't stop after 5 pounds, or even 50 pounds? Anorexia nervosa is a severe eating disorder that involves low intake of calories and low body weight. So, to diagnose anorexia nervosa, there are 3 criteria that have to be met from the Diagnostic and Statistical Manual. The first criterion is restriction of energy intake and minimally low body weight as a result compared to others of the same age, sex, and developmental trajectory. The second criteria is an intense fear of gaining weight, becoming fat, or persistent behavior that interferes with weight gain, even though the person's at a significantly low weight. And the third criteria is a disturbance in the way in which one's body is perceived and experienced, undue influence of body weight or shape on self-evaluation, or persistent lack of recognition of the seriousness of the current low body weight. So, there are 2 different subtypes of anorexia nervosa. There's restrictive type, in which weight loss is mainly accomplished through dieting, fasting, and excessive exercise. And there is binge eating / purging subtype, in which the anorexic undergoes recurrent episodes of binge eating, so consuming many thousands of calories at one time, and purging through vomiting, laxatives, other means. To diagnose anorexia nervosa, first you need to make sure that it's not actually a condition that just looks like anorexia nervosa. There are a wide variety of medical conditions such as gallbladder disease and other gastrointestinal diseases that can appear to look like anorexia nervosa. Major depressive disorder shares a lot of the cognitive and emotional symptoms with anorexia nervosa. Schizophrenia, substance use disorders, social anxiety disorder, obsessive compulsive disorder, body dysmorphic disorder, another eating disorder called bulimia nervosa, and avoidant and restrictive food intake disorder all appear to be similar to anorexia nervosa in their presentation. So, some statistics on anorexia nervosa. 0.9% of women and 0.3% of men develop anorexia nervosa in their lifetime. The age of onset is usually adolescence to early 20s. The average length of the disorder is 1.7 years. And the mortality estimates are 4.4 to 10% for someone who's been diagnosed with anorexia nervosa to die from direct results of the disease. So, for the biology of anorexia nervosa, heritability estimates range from 50% to 90%. So that means that if you're twins with someone and you have anorexia nervosa, odds are 50 to 90% that you would also develop anorexia nervosa. There's a much higher concordance rate in monozygotic twins than dizygotic twins, so identical twins versus fraternal twins, as most people call them. So that indicates that the closer genetics means that it's more likely for people to develop anorexia nervosa. There are 128 polymorphisms and 43 genes that are involved with eating disorders, emotions, motivation, reward mechanisms, and personality that all could potentially impact people developing anorexia nervosa. And abnormal estrogen receptors having an impact on the disease may explain the sex difference. So another part of the biology is a little-known disorder called PANS, which stands for Pediatric Acute Onset Neuropsychiatric Syndrome. This tends to occur in children after they have a Streptococcus A or other type of infection. It involves rapid onset of symptoms of disorders like anorexia nervosa, obsessive compulsive disorder, and tic disorder. However, it's still under research since it's a very controversial topic. The cognitive perspective of anorexia nervosa patients tend to have flawed cognitions. They have a flawed interpretation of their body size, and they place a disproportionate amount of their self-esteem on how they look to others. Anorexia nervosa is found most often in those with high levels of anxiety or obsessive traits, and cognitive behavioral therapy is a common way that it is treated. There is some argument that anorexia nervosa is a culture-bound syndrome, which means that it only appears in certain cultures. Anorexia nervosa is most predominant in affluent, industrialized, developed Western countries, in females and Caucasians, those in middle to upper class, those with body-focused occupations, those with traumatic experiences in their past, and in modern times more than historical. So there are a couple different angles from which treatment can be taken. Counseling is most common. The most effective treatment that's been found is family-based treatment, in which the entire family undergoes counseling and does work with the patient's food intake. However, this is extremely time-consuming and it's not very common. So cognitive behavioral therapy is the most common form. This involves only therapy of the patient themselves. And group therapy is another alternative that can be added on top of one-on-one cognitive behavioral therapy, or it can be given just on its own in more mild cases of anorexia nervosa. Another option is medication. This is generally added on top of counseling, not in place of counseling. So most common would be antidepressants, especially the SSRIs, selective serotonin reuptake inhibitors, antipsychotics, lithium, and in some more controversial cases, THC may be given to increase appetite. However, those are significantly less common means of treating anorexia nervosa. So, now you know a little more about anorexia nervosa. However, I would still leave the diagnosing up to the professionals. Thank you.